reason we didn't have those vaccines approved was because we actually eradicated that one with a lot of the infection control measures we've become very familiar with COVID. But the work for all of those vaccines and therapeutics started there. Next slide, please. And a bit of a busy slide, but we are very confident now that this virus emerged from animals, and there's been a lot of other examples of viruses also crossing over from other animals, particularly bats, for a variety of reasons. And obviously Ebola is a little bit relevant at the moment as well, with some recent challenges with that virus. And obviously locally, the example there is Hendra, which is just up the road, right near where I live. And that also crossed over from bats into animals and then humans as well. So it's not the first time that happens, it actually happens quite a bit. And so if we go down to the next slide, there's a lot of recent work that's been done, and I don't know that projects very well down the bottom there, but it really does appear that there was some events that led to this virus emerging from that market. And the other thing that makes it more likely is there was actually two distinct lineages that emerged almost at the same time, meaning that there was probably two crossover events with two different strains, or what we now would refer to as variants, that were actually detected at a similar time. So if it came from a lab, it'd be very unlikely that it was actually some different lineages that emerged at the same time. Next slide, please. So where we're at the moment, we keep scrolling down. So if you believe a lot of the messages in social media and the media, COVID is something we don't have to worry about anymore. So my take on that is that's also false, clearly. If we keep scrolling through, again, a bit of this is chopped off. The seventh largest pandemic in history now, with over 600 million cases and over 6.58 million deaths. So obviously the burden of disease is is very significant. Keep scrolling down. And the recent numbers, while we've seen some trends in the right direction, obviously those case numbers are still far from zero, and in many parts of the world they're actually trending up at the moment, and I'll talk about that in a moment. Next slide, thanks. Just to show the recent numbers, obviously a lot less, but that peak was very significant. Scroll down, thanks. So we had our first case over 1,000 days ago now, which it seems in some ways like a very long time, some ways like a very short time, but over 1,000 days since our first case. And we've actually exceeded 10 million cases here and nearly 15,000, just over, sorry, 15,000 deaths. And that seems like a lot. I was at a meeting last week. Some of you know I've just recently travelled back, so if I look a bit sleepy, it's the jet lag. And I presented this same data at that meeting, and some people from Brazil said that they're having that same number of deaths every 2 weeks. So the fact that we've had 15,000 deaths is obviously a tragedy, but relatively speaking has actually been pretty good compared to other standards. Next slide, thanks. And so if you look at our cases, it's really clear we had next to none for a very long time, bit of a spike, and with the accuracy you can't really see it, but a bit of a spike late last year with Delta in Melbourne and Sydney. But if you look at this year, obviously we've had very high numbers of cases for a variety of reasons. Next slide, thanks. Again, just the numbers. Yeah, next slide. So if you look at how we went compared to the rest of the world, it's actually a pretty big green tick, although a lot of people have been very critical. A lot of the reports released recently have led people to be very critical of our response. But realistically, if you look at where we've positioned ourselves globally, it's actually been pretty good. So next slide, thanks. You can see we've had those, it's been called 3 waves of Omicron. It kind of looks like 3.5 there in many ways, but it's been called 3 waves. Next slide, thanks. But next to nothing early on. And I think everyone's very familiar with the fact that we have this zero COVID strategy, or this aggressive suppression elimination strategy, where we used all the available tools really, probably to good effect. Next slide, thanks. But there's probably a variety of reasons. A lot of it was luck. A lot of it was where we're positioned, and the fact we're an island nation. I was speaking to some other people in Asia at this meeting, and they couldn't isolate themselves from other countries. They couldn't close their borders. And so there's a much greater interdependence for a lot of other countries on neighbouring countries, whereas we were able to shut ourselves down. But the bottom of the slide outlines the challenges, and I think that's the thing that in retrospect is becoming increasingly clear, is that all of these things, whilst potentially effective, came at a very significant cost, which is why they couldn't be continued forever. Next slide, thanks. Zooming in on those 3 waves. Next slide. And if we look at what happened in Queensland, we had a similar story to the rest of the country. But the important thing with Omicron, for a variety of reasons, is that pretty flat red line at the bottom, there's been a bit of a disconnect between ICU cases and the case numbers, and that's for a variety of reasons. Again, a lot of people are saying Omicron is not very severe, but it's probably because a lot of strategies, including high vaccination coverage, that meant that while we saw those very significant waves of cases, we didn't see the same in terms of intensive care admissions. So again, meaning that a lot of the things we did were probably very effective. Next slide. And I'll go through these fairly quickly. Why did we have such a big wave of Omicron? And a lot of people like to debate the different strategies and what we did and when we removed them, but a lot of it's to do with the virus. And again, there's lots of words on here, but BA4 and BA5 were more infectious than BA2, which caused that wave in sort of March, which was more infectious again than the first Omicron, which we call BA1, which is what caused that wave that started in the middle of December. So a lot of this is down to the virus and its properties. But you can see there I've listed a few other things, particularly also that people's perception of risk after lots of people had Omicron, and those first and second waves meant that a lot of people stopped doing those things. They kind of stopped being afraid of it. So they stopped doing all those things that probably helped in terms of mask wearing, social distancing, and even getting tested and staying home. And we've probably progressed even further along that same path now. So we'll come to it at the end about some of the recommendations, but I think we need to keep doing a lot of those things within reason, of course, not going back to being locked down, but still making sure we have some strategies in place. Next slide. And so I'll just quickly fly through some comparisons. If you look at our case numbers during that recent wave, we're one of the highest in the world. Next slide. Look at our case numbers cumulatively, it's actually been pretty high, but a lot of that is probably access to testing and good reporting systems. So you can see a lot of other countries that probably had a lot more cases, but probably didn't have the same facilities to report those. Next slide. If you look at deaths, it was pretty bad during that wave for us. Next slide. And if you look at that as a sort of heat map, so the intensity there is indicated by a darker shading. So during that wave, we had quite a few deaths, which obviously is pretty terrible. If you look at next slide, how we compared, we're still pretty light overall. So again, coming back to the fact that while we obviously didn't do everything perfectly right, and some of those reports have been pretty scathing, you look at our death rate overall, we've actually done pretty well. So next slide. Again, and so a lot of the chat at the moment is about variants and subvariants, and the terminology is really confusing. Again, there's lots of words on this slide, but basically what happens is the virus is continuing to evolve, and a lot of people are talking about what the virus is trying to do and all those things, but really these changes are quite random. But when they happen to give the virus some properties that help it, so it might be that it's more infectious or it evades our vaccines or our immune response from being infected before, we kind of select that out. So it's like natural selection happening in a really rapid rate of time. And that's what's really happening at the moment. And so we saw that with obviously BA1 and BA2, BA4, 5, and it's actually, if anything, sped up at the moment. So this has become even more confusing in terms of the terminology, even though we thought that probably wasn't possible. Next slide, thanks. So, and again, this is just to show we had BA1, which is more infectious than Delta before it, a little bit less severe, but not fair to say that it was mild. BA2 was a bit more infectious again, another wave, that was March. Next slide. Thanks. We had BA4 and 5. That was the one that caused that really big wave in June, July. Next slide, thanks. But now there's heaps more. And again, as I say, the terminology is more confusing, and it really depends on where you are. And again, you don't need to know these, but there's BQ1 and BQ1.1, BA 4.6, and XBB are the main ones that are around at the moment. And a lot of these have come from BA5, so they're kind of like the sons and daughters of BA5. But then what they're also doing is some of them are mixing together. So there's been some sons and daughters of BA2 that have joined together. So it's really confusing, but it does mean that we can't get too complacent at the moment. That's the main thing. And some of these are more infectious again. Some of them evade protection from vaccines. And concerningly as well, some of them evade some of our therapies as well. So we've got some great antibody therapies. We had all these options at the start of the year for people that got sick, and now most of those don't work anymore. So again, it is just a bit of a warning sign that we need to not get complacent just yet. Next slide, thanks. But as I said, our tools are improving, and we'll scroll through these really quickly. So next slide. Australia has heaps of vaccines. That's basically what this slide shows compared to a lot of other countries. We basically bought 10 doses per person. So which again is a little bit wasteful, and I think highlights the fact that we need to share them around better than we have so far. There's been a lot of talk about that. Next slide, thanks. Keep going again. Just to highlight how the vaccines work, and this is relevant for a point I'll make at the end. So we've got the mRNA vaccines, which are the instructions to make the spike protein. Next slide. The viral vector vaccine, which is AstraZeneca, which we don't really use now. We had those same instructions to make the spike proteins, the bit on the surface of the virus, that we delivered with a harmless virus to get them into the right spot. Next slide. And then we've got the protein vaccines, and this is something that most people don't know about and haven't used yet. And it's a really important thing that we have available that might help. One of those, if we go down a slide, is this one we call Novavax, which I like to highlight because that actually started us during in Australia. I did a lot of the work on that vaccine, and so now that's available. But the messaging has been really confusing. Basically, ATAGI made a bit of a mistake, and they said, oh, you can only have this one if you can't have the other ones. And so all these people thought you had to get a doctor's letter, and we've got 51,000 doses that, sorry, a bit more than actually. Can we just go back to the slide? I think it's back one more again, just to the slide that had all the doses, 51 million doses, sorry, if we go down back to where we were. But we've used only thousands of doses so far because a lot of people just don't know it's available. And that's a vaccine that doesn't have a lot of the problems some other vaccines have. And also showing that it might be a bit better against some of those new variants. So an important one to understand, and hopefully if we get that message out, we might be able to encourage a few more people, particularly get their boosters where we're really lagging at the moment. Next slide. So just to sort of go through chronologically where we're up to, and I won't go through all of this. We've had our vaccine since the start of last year. And should we scroll down, next slide, thanks. And just to show, so this is my kids getting their first and second doses. Well, we've actually done a pretty bad job at getting the young kids vaccinated. So again, it was the start of the year that we had vaccines available for 5 to 11-year-olds. They had the opportunity to get their second dose, not yet a booster, but kids that have medical conditions can get a booster. And now there's even an approval for the 6 months to 5 years, but again, it's only in kids at a higher risk. And again, the uptake of that has been really low. So even a lot of those vulnerable kids haven't had the opportunity. And again, we've got this winter booster recommendations, 4th dose, and a lot of people haven't had a chance, haven't taken that up. And just to show some of that, so we did a great job with our first 2 doses, one of the highest countries in the world. So we've got over 95%. But if we go down, and again, just some red circles, we've done a really bad job so far with boosters. So we're really on a par with a lot of the lower countries in terms of where we sit with our booster rate. That's our 3rd and 4th doses. Next slide. And you can see our interval for those boosters got shortened in terms of our recommendations as the case numbers started to take off, but our rate really didn't match the eligibility and still hasn't caught up. Next slide, thanks. There's a lot of reasons for that. A lot of things are pretty obvious. A lot of it is that people started to spread that message, Omicron's mild, don't worry about it. COVID's over, it's done, and all those messages. And as I showed with all those new variants and the case numbers, it's not necessarily the case. So a lot of that messaging made people think, why would I bother getting that booster? I don't need it. And there's even a lot of talk about that now. And it's interesting that some of the discussions are really polarizing. There's people that want to get all these extra doses that are getting told they can't, and then all these people that are eligible and aren't getting their vaccine. So we're in a kind of really tricky situation with the messaging right now. Next slide, thanks. And of course, a lot of people are just over talking about it. And I think that's why we have to be really careful about getting the right messages out there. I think a lot of the discussion about where we've been, it's probably not all that helpful. A lot of criticism of these restrictions that we had that probably helped that people didn't like. And we just need to focus now, I think, on what we need to get done, which is the basics, particularly around vaccination. Next slide, thanks. And so I think there's a lot of confusion as well. A lot of people don't know what they're eligible for. And again, there's lots of words here, but really just to highlight how confusing some of that messaging still really is. So basically, most people are eligible for a 4th dose, but some of the messaging from the regulator and ATAGI has been a little bit ambiguous in terms of who should get it. But really, in my opinion, it's anyone who's 30 or over really should have 4 doses by now. Next slide, thanks. And just to show, I think I've got some red circles on that our rates of that uptake have been pretty bad and remain so. Next slide, thanks. And so a lot of people say they don't work or they're not required, but of course that's not the case. And so we do still need to rely on vaccines. And the reasons for that is, and it seems a little bit paradoxical that as our case numbers went up and these new variants emerged, we've taken away all of our measures that were helping people. We don't need people to be vaccinated as travellers. We're not testing anybody. We're not capturing a lot of the test results, etc. We're not even getting people to isolate now if they're positive. And so that's why we have to really focus on what's left, which really is vaccination. And next slide. And our vaccines have also just improved. And again, I think this is a bit confusing. So those different ways of giving those vaccines, they're pretty easy to update if we need to. That's why we can make those vaccines in the first place so quickly, because it's easy to change what they protect against. And so that's what we've done now with the new variants. So if we go down a slide. So now we have Omicron specific boosters. And, it was confusing how they were approved. The first one was actually available on the 10th of October, and a lot of people still don't know about this. So that's one that protects us against not only the original strain, the Wuhan strain, but we've added in, so we've not changed it, we've actually added together BA1. And the thought with adding two different ones is you get a broader response that will hopefully give better protection against all the current variants and maybe even the variants that are coming through as well. And so we're not recommending that as an extra dose so far, but if people are eligible for a booster, you now have an option of getting an Omicron specific one. Next slide. And look, I might actually leave it there because I think I've been rabbiting on for a bit long. Just to say the next bits, actually, can I just scroll through? I'll get through to the final messages. Really quick. Okay. The bits I just skipped through are that we've got therapies now, and a lot of people who are eligible for those treatments when they get COVID aren't getting them. So it's important, particularly if people are high risk, if you've got lots of medical problems, maybe even speak to your GP to come up with a plan for if you maybe got symptoms of COVID. Because one of the big challenges at the moment is a lot of people aren't getting tested and don't know how to get tested when they get COVID. So you can talk about that up front. And so that's a message that I think we should get out there, particularly the highest risk people, because to get access to those tablets, you need to have had a proper test. And also the fact that there's going to be more improved vaccines coming as well in time. So here's just some takeaway points. So we can't assume that COVID's gone away. And a lot of people are saying it's just going to get more mild or less severe as it evolves. And that's not necessarily the case. As I mentioned earlier, the changes are quite random. And we've been fortunate that's been the case with Omicron, but the next variant could be more severe again. And we're going to keep seeing peaks and troughs, and it's not just going to fade away. And what causes those peaks and troughs, we can't predict. So some experts in our country said, yep, December, it's going to happen. But it could be 2 weeks away, it could be 6 months or more away. But we will see another increase in transmission. And if we don't get people boosted or up to date with their vaccines, the consequences of that wave will be much more significant than they would have been otherwise. And the other thing is, obviously, we've taken away the rules around masks and getting tested and isolating, etc. But that doesn't mean those things aren't important or don't work. We're just asking people to do it now on a voluntary basis. And so I think that message has been lost. A lot of people are saying, oh, they've said we don't need to ever wear masks anymore. But what we've done is we've said, well, masks still help, but we're not going to make you wear them. So things like masks do help. And really importantly, if people have symptoms, they should get tested and they should stay home while they're unwell. So whether that's from work or other things. And this is what we've been saying forever about the flu, but just no one ever listened to us. But it's really important, particularly for COVID moving forward, if people do have it, that they stay home on a voluntary basis. So next slide. But having said all that, it's not all bad news. And I think this is the other important thing as well, is that complacency is probably our biggest enemy, but our tools are getting much better. We've got the improved vaccines, we're going to get more vaccines. Our therapies are working really well. And so far the tablets, those new variants haven't been affected in terms of how well those tablets work. Our testing is getting better, provided we keep using it. So we're hopefully even going to have testing that you can do at a GP office that will be a PCR rather than rapid antigen testing. And so there's going to be some of those rolling out as options. And of course, the other thing that I haven't gone into any detail is about long COVID. So obviously, the consequences of COVID are far more significant than just ICU and deaths and things like that. And the burden of long COVID is just continuing to rise. But hopefully soon we'll have some ways of managing that a bit better as well. Next slide. So what should you do? So being up to date with your vaccine is really important. And as I said, the recommendations are a bit confusing. So if you're not sure, GPs and pharmacists are really good resources for that. I think the ATAGI and the government websites are still really confusing. But basically, if you're over 30, it's recommended. And I would think that that's something we should strongly consider. And don't forget your other vaccines, because we're seeing other vaccines start to fall away. We've seen some issues with some other vaccine preventable diseases as a result. And so we need to make sure we keep focusing on our other vaccines as well. Next slide. And the basics. And as I said, just because they're not in the rules, that doesn't mean they don't work. And it's really interesting that, you know, mask wearing in Australia, if you wear a mask on a train and things, now people will often say, why are you doing that? You don't need to do that. So in many ways, people are getting criticised for trying to do the right thing. Because in many other countries, if you get on a train without a mask, they'll say, what are you doing? Particularly if you cough or sneeze, people will actually tap you on the shoulder and say you need to have a mask on. And so I think we've done a really bad job of that here. We still need to try and facilitate that and encourage. And we're getting a lot of questions in, you know, GP clinics and healthcare facilities where a lot of the rules have been taken away. But again, it wasn't that you shouldn't get people to use them. It's now up to you to have those rules or not. And it's still up to you if you want to have, if people need to come to your clinic or your facility, that if you want them to wear a mask, that's something that you can ask them to do. Next slide. Testing, it's a bit more complex, but still really important. Some people have said don't get tested unless you're really high risk and, you know, need the hospital-based therapies, but I still think it's really important that we keep track of what people have. And obviously we've got tests that not only pick up COVID, but the other viruses as well. We've seen big challenges with RSV, and the other side of the world now is seeing particularly their pediatric emergency departments full of kids with RSV. So that's a virus we saw at the start of this year a little bit, but the other side of the world is having huge problems with that. So again, testing is really important in my opinion. Next slide. And so that was basically what I wanted to run through very quickly. Obviously happy to take questions, but just really to highlight that things are pretty good here now. It's not going to stay that way forever. We are going to see more waves, and all those basics that really helped us that now are not entrenched in rules to make us do it are still so important, and we need to keep encouraging people to do that. And while it's really confusing, you know, there are still ways of getting the right information. As I say, GPs and pharmacists can help with the vaccines. You know, people like me are always happy to help as well. And you know, what we are trying to do is encourage there to be some more communication around this stuff so that people do understand the importance and the rules and what's available in terms of vaccination in particular. So yeah, happy to take any questions.
Great. Yes, hey, thanks for the presentation. I was going to ask, in terms of the long-term, you know, symptoms and effects of COVID, is there any research or any plan in order to, you know, mitigate it or, you know, help out, I guess, some sort of therapy?
Yeah, great question. So there's heaps of work happening. It's a really active space now. It was largely ignored for, you know, probably the first 2 years of the pandemic, but now, and particularly recently, the burden of long COVID has gone up significantly. So some good stuff happening even locally. Some people are trying to work on a better test to see if people have it and what might be driving it. So we're really at the stage now trying to understand it better. And hopefully that will fairly rapidly translate into things we can do to improve it. So at the moment, there's not a lot of really good research on exactly what works. A bit of stuff today, but even something like naltrexone in a low dose can help with some of the symptoms. But what I think is starting to emerge more and more, and we've been a bit slow in Queensland in particular, is dedicated long COVID clinics that have a multidisciplinary approach with, you know, exercise physiologists and physios and psychology and specialists from rehab, ID, respiratory, etc., because it affects almost every organ system. And so, you know, a lot of people have the respiratory stuff, the fatigue, the brain fog, and that's where naltrexone is supposed to maybe help with that. So we're really working hard to try and set up a few more of those combined long COVID clinics where we can at least talk people through and monitor them and you know, hopefully contribute to some of the research as well. So short answer is there's not much out there, but it's evolving quickly, and hopefully we'll have some things locally fairly soon.
Thank you.
Any other questions? Anyone online have any more questions?
Hello, good afternoon, Elizabeth. Good evening, everyone. Elizabeth here. I just have a question around now, the latest, the regulations around COVID. So post government intervention around COVID, and if any member of the community, and I'm speaking about the CALD communities now, if anyone has COVID or suspect to have symptoms of COVID-19, will there still be drive-through clinics for them to go get tested?
Yeah, so I think that's a big issue at the moment, is a lot of the ways we did the testing have all been taken away, same as the vaccination clinics, and a lot of all those resources have basically been withdrawn. So at the moment, there's no drive-through clinics that I'm aware of. I think there's something that a lot of the pathology companies can set up fairly quickly if the need arises, but it's not something we've really planned for all that well. And one of the biggest challenges is we've gone back to needing a form from a doctor to get tested in most situations. I think there's still a very small number of clinics where you can get tested without that. And that's going to make it really hard when we do see cases go up again to get access to testing. So something we're talking about, but it's not as easy as it used to be at the height of some of those peaks. So that's why I think if you're someone who's particularly high risk, so people whose immune systems don't work, for example, or you have lots of medical problems, it might be good to speak to your GP or have a discussion with your patients if you're the GP about a plan for someone who's got symptoms potentially consistent, maybe even give them a request form so they can, and maybe even give them a prescription for the right medication if they're someone who would be particularly high risk and benefit from that. I didn't go through the eligibility for those therapies, but I think we need to be a bit proactive in thinking about who's going to get the most benefit from those and thinking ahead. I mean, at the moment, we probably don't need to do that in a great hurry, but as I say, it's really only a matter of time before our case numbers go up. And the trouble is often we're so reactive that when we get so busy actually seeing these people, we don't get a chance to think ahead and have good plans in place. So, and I'm fearful that we're kind of doing that again with really spreading the message that it's all over and relaxing everything when it is only a matter of time before the numbers go back up a bit.
Do you have anything else to add to that, William?
No, I'm very glad Paul's here to answer the hard questions.
I've got a question, Paul.
Yeah.
So one of the things that we're hearing sometimes is that people don't want to get the third and fourth vaccines because of the side effects.
Yeah.
That they've had a bad effect and basically they believe that the government's not really telling us everything there is to say about the side effects, etc. Can you say anything about, obviously there's a lot of data out there, so in terms of a message to the communities, especially the ones who are worried about the side effects, what would be a simple message to talk about in relation to side effects?
I guess the main thing is yes, we need to have an open and honest discussion about that, and yes, the vaccines do have side effects, and one of the most notable, particularly with the mRNA vaccines, is that myocarditis, that inflammation of the heart muscle, and we do understand who's at the greatest risk. That's young males, but there's a lot of really good information on that now. We know that COVID infection itself does that at a much higher rate, probably at least 7 times greater. So your risk of that exact same thing is much higher with the disease than it is with the vaccine. So even though we do see some from the vaccine, it's prevented more than it's caused. And the main thing about that is the vast majority go away by themselves in a short space of time without needing any medical intervention. So it is a recognised side effect, but one that the virus itself does a lot more. Having said that, we've also reduced the dose. So in the kids vaccine, it's a lower dose. And so the risk is actually much lower in the younger kids. So that 5 to 11 group, it's a much smaller dose. So we don't see it as much in that group. And the other thing is Novavax, that other vaccine. And that's where that vaccine was really, I think it's got a great position, is that if people have had adverse events or in any way apprehensive about getting another mRNAs, Novavax is a completely different type of vaccine. It's a protein instead of an mRNA. Again, it does have some side effects, but a little bit different to the mRNA vaccines. And there's a lot of good information coming out about this now, and we do need to start having conversations with people about this. I mean, one of the things that I often say, because I see some people that have had nasty reactions and counsel them about the next one is, unfortunately, there's no medical intervention that's free of side effects. And we see people that have a life-threatening reaction to a single dose of Panadol, for example. And we carefully assess the vaccines in the trials, so we didn't cut any corners, and we actually carefully assess moving forward as well. So all those side effects are submitted and analysed, and if we see a rate that's too high, we will change how we use the vaccines. And we actually did that in this country with AstraZeneca, and we probably did it a bit too early. But we wanted to make sure that we were protecting people as much as possible. So I think we do a great job of monitoring and communicating that. And I think that's part of the problem, is that now we probably talked about the side effects a bit too much. People have this perception that they actually happen at a higher rate than we actually really do see them. And the other challenge we're facing now, and I had a discussion about this with someone today, is that because nearly everybody's had at least 1 or 2 doses, anything that happens after that, people have a tendency to say, oh, it's probably because I got my vaccine, whereas a lot of these things would have happened anyway. So yeah, it's difficult, and these conversations are still ongoing. But as I say, I think it's just having the information at hand and having these conversations and listening to people's concerns, because a lot of people do have genuine concerns about what they might have seen. Or thanks very much. Talking too much. Thank you. And I think it's about having a conversation. And as I say, when we do, we can say that, yeah, sure, they do have some side effects, but what they're preventing is far worse than the side effects that we see.
Any more questions online? No, doesn't look like it. Or in the room, yeah.
Yeah, I think in the community, what I've been seeing is people who got long COVID, concerning about their health. Some of them saying they have been experiencing fatigue as well as brain fog. Is there any treatment available?
Yeah, so the only thing, and it's such an interesting phenomenon, this long COVID, and we actually have seen fatigue syndromes with a lot of other infections in the past. Q fever, for example, Lyme disease is notorious for this, and so it's not a new phenomenon necessarily after an infection, but obviously it's one that's happening at a really high rate, relatively speaking. And so the thing that we've got good evidence for with some of those is what we call a graded return to exercise or activity, which is we want people to not do nothing, but we also want them to not do too much. And so that's where the long COVID clinics with an exercise physiologist or a physio to prescribe the right amount of activity that increases gradually. Because we find with these people, if they overdo it, so they have a good day, they go to the shops, go to the gym, do everything, and they can't get off the couch or the bed for 2 days, then they feel good again and they do the same, and they get into this really big cycle of having good days and then being completely wiped out. So holding back on the good days and just doing a bit more every day is something that can help. I read a thing today that low dose naltrexone might help with the brain fog. That's still very much research, not prescribed. But I think over the next few months, we'll start to have a lot more that we can do to help these people. Of course, the other thing to say is that there's really good evidence that if you prevent COVID with a vaccine, you can't get long COVID. And even if you do get a breakthrough infection as a vaccinated person, your probability of getting long COVID is less. That's a really useful thing, I think, to talk about in terms of the pros and cons of the vaccine. The vaccines probably help prevent a lot of cases of long COVID.
Any other questions? All right. I think I might thank you for your time, Dr. Griffin. So